Okay, welcome everyone. Thank you for joining us for our 18th annual COPD Education Day, Living Our Best Lives. My name is Valerie Chang. I am the Executive Director of the Hawaii COPD Coalition, and I am a patient thriving with emphysema. Thank you all for attending, new attendees, folks who come every year, and our Zoom friends. We hope you have had a chance to visit with our many exhibitors upstairs. They will be here through 1 o'clock, so if you haven't had a chance to visit, you can visit after the presentations this morning, and they will be happy to talk to you. It is okay to eat quietly during the presentation. It is being recorded, so please be sure to minimize noise. If you're on Zoom, please stay muted throughout the program. If you have questions or comments, you can post them in chat and we will see them and make sure we address them as well as we can. Please silence or turn off all your electronics for all our friends on Zoom, and everything has to be using a microphone. There will be 2 microphones available, so if you need the microphone, please raise your hand and a microphone will magically appear through our wonderful students. And now, without further ado, I'd like to present Dr. Kathleen Kozak, who is a physician and also a board member of the Hawaii COPD Coalition.
Thanks, everybody, and welcome to the Hawaii COPD Coalition Annual Conference. We have some great speakers today. You can see the agenda towards the left. We've got a wonderful Mythbusters that I'm going to help Maya Nordstrom do, and we also have John Torrence, Deborah Weber, Valerie Cacho, Annie Madar, and Tyler Miller. So you're going to have a chance to hear all of those folks. This year, we're accepting questions at the end. Valerie mentioned there'll be 2 microphones floating around in the audience. So just raise your hand and we're more than happy to direct the microphone to you so everyone online can also hear. If we can't get to any of your questions, we'll answer them at the next support group meeting. Those are held on the 3rd Wednesday of every month from 10 a.m. to noon Hawaii time. And links will be in some of the paperwork that you checked in and received from our wonderful registration desk. Keeping in mind, make sure that you parked well. Apparently towing is a thing. So if you didn't park somewhere that you think is legal, let us know and let the registration desk know. And if you haven't met Queen's staff, Erin, she's giving out some of the validation stickers as well. Now the bathrooms are in the back, down the hall, towards the right. And some of you have asked how you can help support the Hawaii COPD Coalition. There should be an envelope in your bag should you want to. You can put some donations in there. You will get a tax-deductible receipt, and you can also mail that later as well. Now, the Hawaii COPD Coalition participates in Foodland's Give Aloha program, and if you happen to go to Foodland during the month of September, just remember 78740, kind of like planes, a 78740. And it's just this month, but you can also go ahead and help support the COPD Coalition that way. One of our speakers, John Torrence, almost took 4 planes to get here because they were all delayed, so 787 4 times. There you go. And what I'd like to do is welcome my first wonderful co-speaker. Maya Alba is a nurse practitioner specializing in COPD and other lung conditions, and we're going to do Mythbusters, questions and answers about COPD. All right.
All right. Hello, good morning, everyone. Thanks for coming. All right, so we're going to do Mythbusters this year. We did it last year, and it was very popular, so I added some slides, took away some slides, but pretty much we'll go through some myths that are very common.
First, let's go over a definition of what is COPD. Maya?
All right, so COPD is actually a group of disorders usually encompassing emphysema, chronic bronchitis, but also chronic asthma. So that third part, that chronic asthma, people don't normally think about, but actually if you have asthma and it's not properly treated throughout the years, you could actually have COPD. And as far as COPD, if you're not already familiar, C is for chronic, which means this is a daily process that people have. The symptoms are daily, it's progressive, and it's something that doesn't go away. Obstructive talks about what happens in patients with COPD, where basically you're not getting enough air in and out of the lungs. And P is for pulmonary, so it's Latin for lungs, and disease, again, it's a chronic condition, that remains with you.
Okay, so our first myth, if I never smoked, I'll never get COPD.
That's a lie. So the truth is that not all cases of COPD is caused by smoking. So sure enough, yes, smoking does cause COPD in many patients, but actually not all smokers even have COPD or develop COPD. Other causes is like secondhand smoke, especially as a child. So if you have asthma as a child and were exposed to smoke, that could actually change your lung function, and as you get older, you could actually get COPD, even if you weren't the one specifically smoking. Air pollution is another big one, especially if you were like living next to some of the coal factories. So we have some patients that lived in Eva Beach by the coal factory, and they were having horrible lung, symptoms, and it turns out they had developed COPD even if they weren't a smoker. Other things are workplace exposures, dust, fumes, vapors, chemicals, things like that. But also home exposures, especially if you have like wood burning stoves or coal stoves, you could actually expose yourself for those fumes and vapors, that those dust particles too, they could cause you to have COPD in the future. I had some patients who lived in Lanai or Maui, and they would run and chase after the pesticide trucks. So some of those patients actually had developed COPD later because they were frequently exposed to those vapors as well. There's also a genetic component for some patients with COPD, and it's called alpha-1 antitrypsin deficiency. So generally, if you're 30 years old and all of a sudden you start having symptoms of COPD and it looks like, oh yeah, you have a lot of emphysema going on, we're never a smoker. It's one of the tests that we do right away to see why you have COPD at such a young age.
Okay, the next myth. Shortness of breath is the only sign of COPD, and having a smoker's cough is normal.
Also false. So truth, shortness of breath can be, one of the red flag symptoms of COPD, but also chronic cough. So this chronic cough that some patients have, they're like, oh, it's just my smoker's cough, it doesn't matter. It actually does matter, because sometimes when you have a chronic cough, it might not just be your asthma or your COPD, it might be something more serious. And later on in the next presentation, you're going to learn about something that's very prevalent here in Hawaii called Nontuberculosis Mycobacterium infection that could cause chronic cough, excessive phlegm production. So it's important, even if you think you know why you have a cough, like, oh, I'm just allergic to, the dogs, my neighbors or something. If you've had a chronic cough and it's been more than 3 months, go ahead and bring it up with your healthcare provider, because it might turn out, oh, you might actually have developed COPD or something else that's going on that's important to recognize. Wheezing is another important symptom to look at as well, and to bring it up to your healthcare provider. And then also, if you have like recurrent lung infections, like you just keep on getting a cold and it turns into bronchitis, and the cold that you're having is, you think, okay, maybe 3 to 5 days you have a cold, that's normal. But if it's lasting 2-3 weeks and you're having increased shortness of breath, increased cough, increase of mucus, you really want to make sure you bring that up to your healthcare provider as well.
Okay, if I have COPD, I can't exercise. I've got an excuse.
No, no, no. So exercise is so important if you have COPD. Last year, we actually had a presentation from Erica Saito. She was one of the therapists at Pulmonary Rehab at Rehab of the Pacific, and she mentioned all the wonderful benefits of exercise. So if you have COPD, you actually want to exercise. Not only does it make you feel better and helps with your mood, but it actually increases your lung capacity, your function, your ability to, do normal day-to-day activities like taking a shower, putting on your clothes. If you actually make that effort to exercise, it makes your muscles stronger, not only in your arms and your legs, but also your heart, because your heart is a muscle. And then when you exercise, you want to make sure that you do a variety of exercises that includes stretching, weight-bearing exercise with light weights, and also like aerobic exercise to get your heart rate up. The biggest takeaway is that if you do exercise, do not overdo it. That's really important because you could actually, number one, injure yourself if you overdo it, but you could also actually maybe trigger your COPD and worsen your symptoms. So you want to make sure when you exercise, you're able to have a normal conversation, maybe say 1 or 2 sentences without feeling, short of breath or having trouble breathing. Then you're actually at a good pace. But if you're saying 1 or 2 words and you can't really get it out, you're doing way too much. So you want to slow it down, sit down, take a breather. Also, when you do exercise, you probably want to also check your oxygen level. So many people actually have a pulse oximeter. If you're not familiar with it, it kind of got popular during the pandemic because checking your oxygen level was one of the ways that you knew how severe your, COVID-19, if you had it, could have been. So if you have COPD, you want to talk to your healthcare provider about what's a good cutoff point for you and when you should be worried or at least be more cognizant about slowing down. Your oxygen level should be in the mid-90s. High 90s would be great, but someone's baseline with COPD might already just be at 92. So certainly if you go below that, sometimes your healthcare provider will say, okay, you probably should use oxygen when you exercise, or at least slow it down, take deep breaths, and get your oxygen level back up.
Okay, our next myth, COPD only affects your lungs.
Yes. No. Just kidding. Okay, so the truth is that if COPD is not properly controlled, it can lead to other things all over your body. So COPD is a inflammatory condition. So when you have inflammation in your body and it gets worse with time, you could actually cause other inflammation in the rest of your system, like your circulatory system. So that could lead to high blood pressure, increases your risk for having, heart attack, stroke, and also you're at risk for having infections. Usually we think respiratory infections, right? But sometimes if you're a patient with COPD and say you have trouble getting around and you don't want to go up to go shishi every 5 minutes, so you hold it in, later on you'll hear from one of our presenters about pelvic health and the importance of going to urinate when you need to so you don't get a urinary tract infection. Later on, we'll also hear from one of our presenters about sleeping well. One of the things you can develop if you have really bad COPD is actually sleep apnea. So sometimes if a patient has low oxygen levels when they're sleeping and that gets tested, we also sometimes do a follow-up test and ask patients about, okay, when you do sleep, do you snore, gasp for air? Has anyone ever told you it looks like you're holding your breath or stop breathing when you're sleeping? Because it's important to, identify sleep apnea. Because if you're not breathing properly at night, it's going to carry on during the day and make you feel like you can't breathe during the day as well. And speaking of low oxygen levels, it could also, cause you to have an increased risk for osteoporosis. Our bones actually help produce our blood with our red blood cells, and if they don't properly form those cells because we have low oxygen, the density of our bones could go down and puts us at more risk for having osteoporosis, which means, you know, if you're working out really hard and you fall, you might break a hip, and that's not very good, right? And then as far as COPD, sometimes when you have trouble breathing, it could actually make you feel depressed because you can't do things that you would want to do that you did before. Or you feel anxious because you're worried about not feeling like you're going to be able to breathe in certain situations. Upstairs in our exhibit, there's something called like a coffee stir test. So if you don't have COPD and you're here, either a caregiver or you're a student, or you're just here from the public and wanting to know more, if you want to kind of mimic what it would be like to have COPD, you take a straw and then you put it in your mouth and you breathe in and out with it. And that'll kind of mimic how someone with, you know, progressive COPD might feel when they're breathing. And then going back again to like urination or activities of daily living, that's what ADLs mean. COPD could affect that. If you're having a hard time breathing, you know, just bending over, putting on your shoes, trying to, you know, put on your pants, that could just affect your day-to-day activities.
Okay, a couple more myths. Are inhalers the only treatment for COPD?
No. Later on, you're going to hear from Madar, one of our pharmacists at Queens West, talk about various treatment options. So yes, inhalers are very common treatment, and usually it's the first line of treatment for patients with COPD, emphysema, certainly asthma. But there's also oral medications. So some of you might be familiar with like prednisone as treatment for patients who have like exacerbations of COPD, or like when you get bronchitis and your cough is worse, you're more short of breath, you're wheezy, tightness in your chest, they could give you oral medications like prednisone. But so many medications, right, have side effects, so we try to avoid that. So for some patients who have recurrent exacerbations, they'll get a medication that's also oral, brand name Daliresp. Some patients take a medication, generic theophylline. So it all depends on, you know, what your symptoms are and how, you know, severe your disease is, that your provider will determine what medications are best for you. A second option that's very common is nebulized solution. So if you haven't been exposed to a nebulizer machine before, basically it's like this small air compressor, and it's connected to tubing and a mouthpiece. And the medication's actually in liquid form, and you put it into the little reservoir, turn the machine on, and then you actually inhale the vapors, and it goes directly to your lungs. Common one is albuterol or ipratropium albuterol, Duoneb. If you've ever had COPD or even just had asthma, bronchitis, and went to urgent care or ER, they're going to put that mask on you, and you know the air, the kind of fine mist is going in. That's actually a nebulizer medication. Supplemental oxygen is also a potential treatment for COPD. Now, when you do have supplemental oxygen, as we'll learn in the next slide, it doesn't have to be, you know, all the time around the clock. Sometimes it's just temporarily used. If you have COPD from a genetic condition, the alpha-1 antitrypsin that I spoke about, there's actually infusions that you could get to treat your COPD if it's from alpha-1 antitrypsin deficiency. Pulmonary rehab is another great treatment, and just because you did pulmonary rehab already once doesn't mean you can't do it again. It's an ongoing process as your COPD, you know, continues to progress. It's always important to go ahead and you know, look into doing another round of pulmonary rehab. I went to the next slide and it's blank, but on the previous slide it mentions surgery. Last year we had a presentation by Dr. Eric Crowley who talked about lung volume reduction surgery. That's actually a surgery that we do for some patients with emphysema, with hyperinflation, where their lung capacity or their lung volumes actually warrant them to get valves implanted into their lungs to kind of turn off the kind of useless top part of their lungs, either one side or the other side. It's important, though, that we identify patients who would benefit from this earlier on, because actually if your COPD emphysema is way too, severe, you actually wouldn't be a candidate for it. So it's important to talk to your healthcare provider about, hey, I have COPD, you told me I have COPD, but I've never seen a pulmonologist before, to, really get down to what my options could be. If you haven't been, referred to a pulmonologist, I'd probably recommend asking your doctor, healthcare provider about doing that. And then the last option is actually like lung transplant. Again, if you're thinking about lung transplant, it'd probably, be important to talk to a pulmonologist first, because again, there has to be certain criteria that has to be met. And then the very last treatment option that's non-medicine, which we love, too much medicine, sometimes too much, we don't like that, is actually just lifestyle modifications. And that's diet, exercise, right? And also quit smoking if you haven't already.
Okay, and I think it's our last myth. When you go on oxygen, you'll have to live with that forever.
The truth is you don't. So there are some patients with very severe COPD who do need oxygen around the clock while they're just resting, walking around, sleeping. But others, they actually only need it kind of in as-needed situations. One of the earlier indications that you might need oxygen is, if you wake up, headache, kind of tired. Sometimes you might just need oxygen when you're sleeping. And that gets identified through either a sleep study or something called an overnight oximetry test that we do. Sometimes this is the first, step in when you actually need oxygen. Another treatment with oxygen is just with exercise. And sometimes patients think, oh, no, when I'm at the gym or, exercising at home. But sometimes just walking could be an exercise, and that might be when some patients or people with COPD might need oxygen, just when they're walking around at home or maybe just when they're out and about. Air travel is another situation where you might just need oxygen just when you're traveling. Last year, we had a wonderful presentation about traveling with oxygen if you have COPD. So it's important to do something called a high altitude simulation test, so you could find out whether you need oxygen in high altitudes. Not everybody needs oxygen in high altitudes when they're in the plane. It might be just when they're walking around in the plane and not necessarily when they're sitting down. Short-term flare-ups could also be another indication for, temporary oxygen use. And also short-term with infections such as like pneumonia, or later on the next presentation we'll talk about bronchiectasis. Sometimes patients with severe COPD, or even maybe not severe, but they might have concurrent bronchiectasis. Sometimes if you have an exacerbation of that, you might need oxygen temporarily.
Okay, I think that was our last myth. Does anybody in the audience have questions, or do we have any on the chat? I don't see anybody on the chat with questions. Anybody in the audience have a question? All right, I think we've busted all the myths, Maya.
Woohoo! And if you have questions and you were just, didn't want to ask them, you could always go to our website, hawaiicopd.org, and you could actually email us as well with questions, or you could actually come to our monthly meetings. We have a support group meeting every third Wednesday of the month at the Straub Library, and it's third Wednesday of the month from 10 a.m. to 12 noon. And then also, if you wanted to learn, and I touched upon our previous COPD Ed Day presentations, we actually have a YouTube site or YouTube channel where our previous presentations were recorded and posted there. Or again, you could go to our website, hawaiicopd.org, and watch those presentations online.
I guess that now means we're going to be on YouTube, Maya. I don't know. Hopefully in a good way. All right, I want to thank you for all of your help in busting some of the common myths that people have about COPD. We're now going to be hearing from John Torrence. He's a patient and a COPD Foundation board member, and he's talking about living well with bronchiectasis and non-tubercular mycobacterial infections. He's the guy who got stuck on all the plane rides. Remember, Foodland, 78740. Please welcome to the stage, John Torrence. Now I'm going to bust my own myth that I know that I was supposed to click on this. There we go.
Well, thank you, Dr. Kozak, and welcome to everyone here and everyone in Zoom land. You know, in today's technology, we have artificial intelligence, and it's making a lot of progress, and you'll hear more and more about it as the days go on. And I thought I'd start with just a little experiment in artificial intelligence, and I can actually sense what questions you might have. It's like, who is this guy? I thought we were here to talk about COPD. What is this bronchiectasis thing? What time is lunch? And how are all these things related to COPD? Well, if you give me just a few minutes, we'll cover all those questions and more. I'd like to introduce myself, or introduce the concept of bronchiectasis and NTM through the lens of my personal experience. And today, you know, we're fortunate to have a great group of speakers, doctors and therapists, professionals of every kind. I want you to know that I am none of those things. I am just an ordinary guy who was living in Maui back in 2009. I was minding my own business. In fact, I was running my own business. I had just built my own house. I had, like everyone in Maui, I had the wife, the dog, and the Toyota. And we finally had some extra time and a little extra money that we could do some social things. And I started scuba diving. So I finally had a life that I thought was going to be pretty good. And I started coughing without any explanation. Perfectly healthy guy who's coughing. And okay, it's a cold or a flu. I can get through that. Just a couple weeks ought to do it. But it didn't go away. So after a while I thought, well, I'm a pretty smart guy. I ought to be able to figure this out. It must be an allergy. So I changed everything about my diet, one thing at a time. Kept on coughing. I thought maybe it's something in my work environment. I'd been around a lot of construction dust and all kinds of toxins and things, so I started changing all of that. Nothing changed. I kept coughing. I got more and more fatigued. I started taking naps during the day. The wife started looking at me like the husband has gotten lazy on me. So nothing was working. 2 years go by. I couldn't figure out the pattern. Middle-aged guy, finally after 2 years, decide I need to go to a doctor. So I report in, get a chest x-ray, and the nice doctor says, oh, you have pneumonia. Here's your doxycycline, away you go. Didn't change anything, I kept coughing. Takes me a while to figure out the pattern is still there. I have not improved. So I go back to the doctor, and this is kind of a weird environment because the doctors are supposed to be the professional. Who am I to tell the doctor that they're wrong when they do this every day? But I'm still coughing. So they give me another antibiotic. I try that for a while. Still coughing. So towards the end of the 3rd year, I remember a particular day. I'm out doing some physical work and I was exhausted. And it wasn't the work that was causing me to be exhausted. It was the fact that I coughed constantly that whole day. And I was so tired and so exhausted and tired of the whole concept that I just drove to the clinic. I didn't have an appointment. I didn't have any reason to be there. I said, look, somebody needs to deal with me today. And I think maybe because I was finally emotionally involved, they took me a little more seriously. They did another chest x-ray, and this time they found a nodule on my lung. Nodule is a fancy medical term that says, we don't know what it is. But they're not willing to say that, so they call it something. We know it's a nodule, which is, we don't know what it is. But it meant they had to at least figure out what it was. Their first thought is it might be cancer. That sounds pretty serious. So we chased cancer for a while, and I get all kinds of tests for cancer, and it's not cancer. And then they start looking for more rare conditions. And finally, after a bronchoscopy, they pull up this stuff out of my lung, and they call it this Nontuberculosis mycobacterial infection of the lung. I got myself an 18-syllable disease. Isn't that terrific? And he says, I don't know where you got this. This is an incredibly rare infection, and healthy males don't get this disease. And I said, well, either way, I've got it, so why don't we deal with it? Now, keep in mind, I'm 3 years into this. It finally occurs to me to call my mom, who has some kind of weird lung infection that I've never asked her what it was. Why didn't I ask her during any of this 3 years? I have no idea. Maybe I need a psychiatrist as well. So I call my mom, and I said, Mom, what's that lung disease you have? She says, oh, it's a funny disease. It's called Nontuberculosis mycobacterial infection of the lung. I said, Mom, I got the same thing. She lives in California. I live in Hawaii. We didn't get it from living together. We didn't get it from the same environment. So what's going on? This is supposed to be incredibly rare. She says, but there's something else. You need to ask the doctor about this thing called bronchiectasis. And I said, spell it. So whatever, we go through this whole thing. I go to the next appointment. I ask the doctor about it. I'm not really getting a straight answer from the doctor during my appointment. At the end of the appointment on my little visit summary, it says, patient has acute exacerbations of bronchiectasis. I'm not terribly sure he knew what it was. And I'm thinking, I don't think I want to be at a place where they don't know what the disease is. So this was not a good start to my professional career in the bronchiectasis world. So let's interrupt my little tale of woe for a minute to give you a little bit of background. And Maya started with a great introduction, but let's give a little more idea what bronchiectasis and NTM are. Now, keep in mind, I am not a medical professional, but these are my observations from being on the other end of the patient experience with the doctor for the last 15 years. Bronchiectasis, as I understand it, is the permanent swelling of some of the airways in your lungs. And in swelling, those airways have become hardened in their position. And in that situation, they tend to collect extra mucus. And even though the airway on the outside is larger, it's being constricted inside. That mucus provides a warm, dark, moist environment, which is perfect for a bacterial infection. So bronchiectasis is progressive. Once you get it, it's yours to keep. There are some companies that are working on therapies for it, but there is no current cure for bronchiectasis. NTM, non-tuberculous mycobacteria, is a normally occurring bacteria in the water supply and in our garden soil. Happens all the time. Therefore, when you take a shower in the morning, I don't mean to scare you, but when you take a shower in the morning and you get hit by all that water, and some of it becomes aerosolized, some of it ends up as fog on your mirror, you were breathing in that bacteria. Luckily, our systems are very advanced. We have all these little white blood cells and neutrophils in our lungs, that in the bloodstream, that identify the bacteria, they isolate it, they beat it up, they kill it, they ship it out. Except that process seems to be about a 12-step process, and in a few of us, one of those 12 steps isn't working quite right. So if you happen to be the guy who has this bronchiectasis, the swelling of the airway, and you happen to have some deficiency in that 12-step process, you're setting yourself up for that bacteria to take hold in the lungs. Luckily, it's a very slow-growing bacteria, So it's not going to kill you tomorrow, but it is going to be more present in the lung over time. And as it takes up space, it makes your airways less productive. Those nodules that tend to collect become collections of, this is my medical term, junk, that are collecting in the lung. And as they collect, they're going to block some of the airways. And like a clever automobile accident in the middle of town, if you happen to get a nodule right at the intersection between two airways, you could lose the functioning of everything that's downstream. So one cleverly placed nodule can cause a problem. Let's keep that cleverly placed comment in mind for later discussion. So NTM, like I say, is a bacteria. It is treatable, but not easily treatable. There are about 200 species of NTM that are known to exist, and the list keeps growing. Only about 15 of those are pathogens to humans, but Hawaii is blessed with a large number of those. And the one that is most common in Hawaii is one that's very difficult to treat. So that's a little background just to lighten things up there. In the bronchiectasis world, in the United States, there's currently about 500,000 people who are diagnosed with bronchiectasis, and there's now at least a dozen people who can pronounce it. So we're making a lot of progress in that area. NTM, there's about 200,000 people diagnosed, and that number seems to be growing at about 8% per year. NTM is technically considered a rare disease because there's only 200,000 people in the United States, which makes it available for extra funding on a technical level. But what we're going to find is the more we look for NTM, the more we look for bronchiectasis, the more we're going to find it. And Maya alluded to this earlier. There is a large overlap between diseases like COPD, cystic fibrosis, pulmonary fibrosis, interstitial lung disease, NTM, all of them having bronchiectasis as a common element. So once you start down this respiratory path, you're likely to start picking up some of these other conditions. And bronchiectasis seems to be this connection between the various diseases. So watch out for that some more. So back to my long, sad tale before I tell you how I finally got over some of this. So I'm diagnosed with this NTM lung disease. I'm seeing a pulmonologist, and he's going to transfer me over to infectious disease for my care. Now, NTM is not infectious. You will not give it to your neighbor, your life partner, or your dog. So why would you send me to infectious disease? Well, it turns out the infectious disease doctors are the guys who sat in front during chemistry, and they actually like all that stuff. So they're really good at figuring out the dosages and the cocktails when you have multiple drugs that all have to work in concert with each other. I am very fortunate to have gone to a great infectious disease doctor who was probably the smartest doctor I'd ever met at that point in my life. And he was very good about understanding not only the disease, but he also understood his limitations. He said, and this is in Maui, he said, I've read all the stories, I go to all the conferences, but I've seen this particular infection 3 times in my whole career. So you really need more care than I can give you. But he started me on a medical path. So I end up with a PICC line in my arm so that I can take my own intravenous drugs. I end up with a nebulizer that Maya refers to so I can do airway clearance, so I can move those little nodules around to keep them from blocking my airways. I end up literally taking home a case of medicine for the first week. A case of medicine. Not a bottle, a case. I have my own IV machine at home at that point. Nebulizers, all kinds of equipment. So eventually I get a referral to one of the top centers in the whole country for this particular disease called National Jewish Health. They're in Denver, Colorado, which is 3,300 miles from here, by the way, so not real convenient, but they are the top experts. They spent a week reviewing all my tests and redoing a lot of tests. and they recommended surgery. So I had the upper right lobe of my lung removed, and that was because of the extensiveness of the bronchiectasis in that area. They felt that there was enough damage there that I would never clear the infection in that lobe, and the drugs would be more effective if that lobe was removed. So I went for immediate surgery and then came back home. I was able to clear that infection. I was on medicine for about 18 months that first time around. So, so having cleared that infection, you know, the discussion from the doctors was, well, just let us know if you have more symptoms. And I decided that really wasn't good enough. I needed to find a way that I could stay on top of this situation. So I decided that I needed to do my own research. Now, if you remember, my mom had this, and they told me this was a very rare condition. Well, what are the odds of my closest blood relative having the same rare condition that I have? So, smarty pants here, I say, I'm going to look this up for genetics. Turns out there was a genetic study going on at the National Institutes of Health in Bethesda, Maryland. NIH is the National Research Medical Center for the United States. It's sponsored by the federal government. It's your tax dollars at work. They're doing a study, and I was able to get my mom and me into that study. So suddenly, the guy who had a doctor who didn't know anything about bronchiectasis, I'm in front of the smartest doctor in the entire country, who not only knows everything, he's written every paper in the land about bronchiectasis and the genetics involved. I've been involved in that study for the last 11 years, by the way. My mom was in it for a couple of years till she passed away. My sister has since developed bronchiectasis, and she is in the study now. So it has been a godsend to be in front of the best doctors, to have the best care, and to be able to refer to, you know, the smartest people in the land when I have a question. So Americans love statistics. So for those of you who are keeping score at home, I thought I'd give you some numbers. It's been 15 years since I started coughing. In the 12 years since I've gotten treatment, I've been through 4 complete treatment cycles, roughly 18 months each. I've been on 16 different antibiotics, 4 inhalers, 2 different types of nebulizers. I've seen 15 different doctors at 2 major research centers and several local clinics. I've had 3 PICC lines for 3 different IV antibiotics for a total of a year of IV medicine. That's 52 bandage changes on that IV line, 104 twice-a-week blood tests, and 1 lobectomy for the surgically remove part of my lung. I've been on meds for 6 out of the last 12 years. I've taken approximately 12,000 doses of antibiotics in that time, some of them costing as little as $4 a month and some as high as $16,000 a month. Luckily, I had insurance. And one medicine that's not commercially available but is best known for treating leprosy. So this is some crazy stuff. And then I've taken several thousand doses of probiotics to keep the antibiotics from destroying my digestive system. So I've been through quite a bit, but the tale doesn't end there. Again, as part of my research, I decided that I needed to know more. In looking up things, I found that there was a nonprofit group called NTM Information and Research, and they had an annual conference. So ever since 2015, I would go anywhere in the country to be at their annual conference because I felt I needed to be the best educated patient out there. If I'm going to survive this, and knowing that my family was at risk, I needed to know what was going on. So after several years, I actually had a little minor speaking role at one of the conferences, kind of giving my 5-minute version of my story. And at that conference, I met someone from the COPD Foundation, and they were pursuing bronchiectasis. They wanted to help patients who had bronchiectasis. They saw bronchiectasis as an area that there was no organization that loved bronchiectasis patients, and I totally had felt that. I felt like I was wandering through the medical desert for a long time, and they kind of took me in as a little bronchiectasis orphan and gave me a place that I could then help develop what would be, you know, a portal for patients in the future. So we developed a patient ambassador program so that people like me can talk to new patients and kind of help them through the process so that patients don't have to go through that 10-year process of not knowing what's going on and being totally overwhelmed with the drugs and the treatment and the big words that doctors like to use on us. We have an information line. It's an 800 number that I answer whenever people call to kind of talk them down, you know, when they've just come from the pulmonologist and they're totally scared of what their life prospects are. We have monthly webinars where we'll talk about subjects that are of interest to patients and caregivers, and so that has grown to be very popular over the last couple of years. And we cover all kinds of subjects, and we take questions from patients to find out what else we can talk about. So how do I live well, which is the original intent of this talk? How do I live well with this disease? Well, first, I find knowledge is power. If I know what I've got and I know what I can expect, then I can accomplish more during the day. In the beginning, I was scared, like most people are. You think you're going to die from this. You think your whole life is just a big science experiment. I had to get that under control, and I had to get back to the idea that I need to go out and do something productive every day. So I may spend time with the nebulizer. I may spend time wearing my vibrating vest. I may spend time taking IV meds from time to time. But I'm going to go out and do something else that's just for me. So whether it's going for a walk, playing with the dog, going visit a neighbor, I have to do something in the real world so that I know that I'm still participating. And I encourage patients to find something that they find value in. So within the foundation, I also found that the more that I did for the foundation, don't tell the foundation this, by the way, the more I do in the foundation, the more value I have, the more I learn, then the more I'm capable of understanding what's going on. And the more I talk to patients, the better therapy it is for me, because I can remember what it was like in the beginning, and I can see how far I've come along. So helping the next patient for me has been very valuable. So now I know how the disease works, and I don't fear it the way I used to. I take care of my lungs both with exercise, nutrition, knowledge, medicine, prevention, but I still need to live my life as I mentioned, many people are scared. In our group, many people are scared to go out, and COVID did not help us in that regard. That COVID kind of enabled this idea that you can stay in your home. Staying in your home is just making you more of a science experiment as far as I'm concerned. So do what you have to do to get out in public and participate in the world so that you can be alive. But we need to get patients more knowledge and better care, and we need to have therapy that's closer than 3,300 miles away that I had to go to. So one of our big initiatives that we're working on at the COPD Foundation is what we're calling the Bronchiectasis and NTM Care Center Network. This is a 3-year initiative where we're hoping to recruit 150 of the major medical centers around the country to become centers of excellence, like that center that I went to in Denver, so that people in Hawaii can stay in Hawaii. You could have a doctor that's close enough that you can get to on a regular basis and be assured that that doctor and his whole team knows the best practices, has the best equipment, and the best therapists available. So this will be a major development. It's a long-term initiative. We currently don't have a center in Hawaii, so if anybody knows a large medical center that would be interested, I'd be happy to talk to them. I'll talk to them anytime this weekend. I'll talk to you by phone or Zoom or any technology. I am heavily invested in making this a success. So I'd love to talk to you today or later about the Care Center Network. A couple other notes. At our table up upstairs, I have a few more of these all about bronchiectasis brochures, happy to share them with you. And I'd like to spend just a minute or two with our respiratory therapist students, as I know you're here today and I'm very appreciative of your attendance. When you get into your career, you're going to be busy. You're going to be assigned 1,000 things to do. And you're going to have one patient after another come in, and you're going to be backed up with all these things. But when you walk into the room, and I'm there, I don't want you to think I'm just your 11 o'clock appointment. I'm a guy whose whole life fell apart. I lost the wife, I lost the house, I lost the dog, I lost the Toyota. The whole thing, because I couldn't manage it all. So when you come in, I need you to come in a little slow. I need you to take your time. You may have to explain it 3 times, because I'm just a little bit overwhelmed at that moment. But what you teach me is more valuable than anybody else in this whole room. Because you remember that little nodule? That little nodule is sitting there at the intersection, right in the main part of my lungs. And it's blocking a whole lot of breathing for me. And if I don't get it moved, I'm not going to be able to breathe. The time you spend with me, educating me about how this machine works, about how the process works, is invaluable. I can clear that nodule out. I can get to breathing. You can convince me to do some exercise, and I can go on and prosper. You are the key to my success. I thank you for being here, and thank you everyone for your time.
Do we have any questions from the audience? There is one in the chat. That's your question, okay. Well, Valerie, who's in the audience, is going to ask her question on the chat. Okay, Val, why do they say bronchiectasis and NTM are COPD adjacent?
Well, as you're coughing with COPD, you're causing damage in the lungs. And that damage tends to be this scarring, this permanent swelling of the airways in the lungs, which is the bronchiectasis. So each lung disease further exacerbates the bronchiectasis condition. And then the bronchiectasis sets up the environment for the bacterial infection. So again, I am not a medical professional. That's my understanding of it. But all of these things have an overlap. There's a large overlap of the population that has COPD to the population that has bronchiectasis. And the more we look, the more we find.
We're going to make you an honorary medical professional for NTM. Any other questions in the audience? We have one in the back. We've got a microphone coming for our folks online.
I want to know if bronchiectasis, if that's how you said it, NTM, does that lead to lung cancer? And the reason I'm asking is because I have a sister who had lung cancer, and she's living with one part of her left lung and one part of her right lung. And then recently, my daughter was diagnosed with lung cancer, and there's a tumor that they're trying to take care of. So I'm wondering if they're related to having lung cancer, and if that's what, because like my daughter, she went through 2 antibiotics and several x-rays before they finally said, oh, you have something over there, you know, on the left lung. So I'm wondering if these 2 things, actually that's what she had and it developed into lung cancer or whatever. How are they related?
Okay, again, not a medical professional, but in my diagnostic experience as a patient, the professionals look for cancer before they look for bronchiectasis because cancer is more common and cancer moves quickly. So they don't have the gift of time with cancer. If they see a nodule, they need to check right now to find out if it's cancerous. So they're looking first to see that it's cancer. When they see it's not cancer, then they start looking for these other crazy things. But thank you for being the 13th person that can pronounce bronchiectasis. So to my knowledge, they're not directly related, but Many times when the doctors are looking, they are thinking cancer. It could still be bronchiectasis. I assume you could have both going on, so some nodules are cancerous and some could be bronchiectasis and NTM. My caution, since you talked about the antibiotics and I didn't get into details here, remember we talked about there's 15 out of the 200 species of NTM are pathogens in humans. Each of those species requires a unique combination of antibiotics. So whereas my first two doctors just handed me an antibiotic off the shelf, which is very common, I understand, in the pneumonia world, because they're just knocking out a whole bunch of disease, in the NTM world, you need the exact combination. So you don't rush into antibiotics until you find out exactly what the species is, and you attack it, very surgically.
That's an excellent question, and I think, John, you're absolutely right on the answer. Bronchiectasis isn't lung cancer, and lung cancer isn't bronchiectasis, but part of the initial clinical evaluation for someone who's had a cough that doesn't resolve with antibiotics, or that just seems unusual, or that requires a chest x-ray for evaluation, that sometimes leads to a diagnosis of lung cancer. And if it was not cancer, they may search for something rare like NTM or bronchiectasis. So it may lead to further investigation, but the two conditions clinically are not the same.
And if I may, to that point, as a patient, one of the things that I learned that was so important was the idea of making sure the doctor knows the history. In my case, the term, and I didn't realize this was a term, the term is a persistent cough, a cough that outlasts any normal cycle of a cold or flu. Make sure your doctor knows this cough isn't something I just got last week. I've been coughing for 2 years and it bothers me. So sometimes, as I mentioned, when I finally got emotional, the doctors got a little more invested. That was my observation. So if this is affecting your life, make sure the doctor knows the extent to which it's affecting your life so that they'll look deeper for some of these more rare conditions.
All right. Thank you very much, John, for sharing your story. Next up, we have Deborah Weber. She is a physical therapist going to talk about the role of the pelvic floor in COPD. Come on up, Deborah.
Okay, well, thank you so much for having me here today. I'm still regaining my composure after John's, I'm so sorry, after John's presentation. I think it's because I'm very passionate about my my patients as well, and this seems very trivial and minimal what I'm going to talk about, but I treat patients who have their lives turned upside down by the diagnoses that they come in with. So sorry, I had to step outside for a moment to regain my composure after that, and how he talked about how it affected his life. My goal with my patients, and again, what I'm talking about today is very trivial and probably one of the least complex parts of the therapy that we do. But my goal is always, with my patients, when they've gone to provider after provider after provider, is I tell them I want to be the last person that you have to go to. And I realize the journey that you've been through to get here. So conditions that I'm treating are things like vaginismus, pain with sex, people who have lost their relationships, people who have gone through fertility treatments. So one of the least complex and most trivial things are how the pelvic floor relates to incontinence. So I'm going to take a breath, and I'm going to think about all that later, more later, process that later, and and talk to you about what we came here to talk to you about today. I apologize. On the computer screen, my slides look a little bit different. There's a little bit more contrast between what's on there. When it's up this big, it's a little bit harder to read. Who am I? I am a physical therapist. I have 25 plus years of experience. I got my bachelor's at the University of Florida in exercise science, my master's of physical therapy at the UNC Chapel Hill, and my doctorate of physical therapy from the University of Montana. I have worked in acute care, orthopedics, pediatrics, women's health, and pelvic health, and I'm a PRPC, which is a pelvic rehabilitation practitioner certification, which is the highest certification that you can get in pelvic health. It takes a lot of continuing education, it takes a lot of studying, and it takes passing a board examination in order to get that. I'm the first and only in Hawaii at the moment. I'm sure there will be more because pelvic health is a growing area of our practice. And I'm the owner and lead therapist at Hawaii Pelvic Therapy. So I know that the title in your handouts is how the role of the pelvic floor in preventing incontinence. But and that is one part of it, one aspect of it. But I want to kind of blow your mind and have you just realize how integral the pelvic floor is to all of our body functions, and educate you a little bit more. I do realize that COPD is a complex condition. My role as an acute care therapist for 25 plus years means that I worked with a lot of people who had COPD exacerbations, and of course they're, in those situations they're like in a life-threatening state. So me coming and talking to them about Kegels and how to work their pelvic floor is insignificant. So again, I'm well versed. I've worked with many patients in acute care that are in dire conditions with lots of other comorbidities. So I don't want to trivialize this, but I do want you to keep in mind the law of minimal gains, which means that we try to attack it from all different angles so that you're able to optimize the function of what you have and what your body is capable at that time regardless of your condition. I have patients that have Parkinson's. I also presented at the Parkinson's symposium, where they come in and they say, I have all this dysfunction, but I have Parkinson's. So they're totally defeated. And I tell them, encourage them that there's so much that we can do within the capability of your body, and that your bowel and bladder function does not have to be the thing that incapacitates you or puts you in nursing home care, or so that you can continue to live your life more optimally. So what we're going to talk about today is actually how the pelvic floor ties into respiratory function, which most people would not make that connection. Just so that you're aware of how much we're doing, how much we're learning, and how specialized this can be. So what is a pelvic therapist? A pelvic therapist is someone who basically specializes in the area between your lumbar spine and hips. The pelvis is made up of three major bones, 3 joints, and then all of the organs that are held in between the pelvis. So for women, the uterus and the rectum and the urinary bladder, and for men, the bladder, the rectum, the prostate, and then all of the sexual organs as well. We have here just a quick overview of the female and male pelvic makeup. Basically, we are specialists in the muscles, the nerves, ligaments, all of the structures in the pelvic area basically forms a hammock at the base of your pelvis, and so that's where we specialize. But you'll see very quickly in my presentation how things start to move up and down away from the pelvis. So what does the pelvic floor do? It's basically those 3 layers of muscles that you just saw in the picture. Layer 1 and 2, if you think about this elevator analogy, layer 1 and 2 help to squeeze the pelvic floor together and like the doors of the elevator closing, and layer 3 lifts everything up so the pelvic floor is rising up toward your head. The purpose of the elevator up action is for continence of urine, bowel, and gas, pelvic organ support, supporting your physical activity or movement or any movement against gravity, sexual health, and assisting in expiration, okay? The purpose of the elevator down action is for bladder, bowel, and gas evacuation, for birthing and sexual function as well, and assisting in inspiration. All right, so I know now your brains are starting to think, how is that going to happen? Yeah, so what did I say? Inspiration and expiration. Okay, it's because in the center of our body, we have our core. Now, most people think about the 6-pack and 8-pack muscles in the front, just because they look good and we're all trying to look thinner, but that is not our core. That's not the only part of our core. The only part of our core. It's actually a system. So if you imagine that in the middle of our bodies we have a cylinder, a canister, like a Coke can that's sitting inside of our body, and it's a really specialized, pressurized system. If anything breaks that seal or that vacuum that exists in the core, you have dysfunction. So when someone comes in to talk to me about bladder leakage, I see it as only a symptom of something leaking in that system, okay? It's not just like, oh yeah, let's just do a bunch of Kegels, let's make it stronger, and you're off, you're good. It is indicative of a wider spread problem that can be anywhere in the center of the body here. So in the front, you do have your rectus abdominis. Deeper to that, you have your transverse abdominis, which is the muscle that we actually pay more attention to. We actually ignore the rectus abdominis most of the time. The transverse sits around you like a girdle. It pulls everything in, and it helps give you that back pressure that you need for inhaling, exhaling, emptying your bowels, emptying your bladder, holding continence. On the sides, you have your oblique muscles. In the back, you actually have your multifidi. At the top, you have your diaphragm. That's the top of the Coke can. And at the bottom, you have your pelvic floor. So you can see how it all ties into this system, and it all works together. So, like I mentioned a couple times already, it's a finely tuned, pressurized system. You can imagine trying to crumple a soda can with just your hands, and how strong that is, how you could barely make it budge or put a dent in it. But if something makes that pressure leak, all of a sudden you have a really weak system, and it just all crumples, just like a Coke can that's empty and the pressure has been let out of it. Proper inhalation versus exhalation. So this is something that's a brain teaser for a lot of our patients, especially if they've had any kind of injury or they have any kind of lung or breathing deficits, is that this system just goes awry and it becomes very uncoordinated. So proper inhalation actually takes place when you expand your lungs. So you take a deep breath in, your diaphragm lowers in order to allow for those lungs to fill with air. Your abdominal cavity expands and your pelvic floor descends. So it's kind of like you're inflating yourself like a balloon. And then on exhalation, the pelvic floor rises, the abdominal cavity or the abdomen comes in, and the the diaphragm rises. So that is the most efficient way to breathe. Now, when you've had respiratory dysfunction for so many years, like I said, this is just, everything's gone awry and it's completely uncoordinated. So people will do a lot of their belly going out when it should be coming in, or bearing down into their pelvic floor in order to take a breath in. So it becomes very confused, and a lot of times with my patients, this is what I'm teaching them to do, is just breathe. Let's remember how to breathe correctly. So if you think about the diaphragm, the respiratory diaphragm, and the pelvic diaphragm, is that there should be a piston action. So as your respiratory diaphragm lowers to allow your lungs to fill with air, the pelvic floor should be lowering again as well. And as you're exhaling, they both should be rising together. We get in trouble when you get this accordion action where they're kind of bumping into each other. One is rising as the other one is falling. And so now you're very inefficient in your breathing and also in your pelvic and abdominal function. So did you know, respiratory students, that you actually have 3 diaphragms in your body? There's the thoracic diaphragm, which is at the top of your thorax, top of your rib cage, base of your neck, where your vocal folds are, and where all the muscles that span between your clavicle and the rib cage and your thoracic spine in the back. That is diaphragm number 1. Diaphragm is really a group of muscles that kind of spans across the body like a hammock. The second is the respiratory diaphragm, which we all think about.
Could you repeat that, please?
I'm sorry? Okay, the thoracic diaphragm at the top is the muscles that go from the clavicle in the front, anterior portion. You have your rib cage, scapula, and the thoracic spine posteriorly. And the hammock, or the diaphragm, basically the definition is a hammock, a sling that kind of traverses from the body, from right to left, front to back. Okay? So I don't know if you can see it up there at the neck level. Then you have the respiratory diaphragm.
Thank you.
Okay, thanks. So respiratory diaphragm is where what we traditionally think of as a diaphragm. So when we refer to the diaphragm muscle, we think about the respiratory muscle that spans the bottom of our rib cage and forms that vacuum seal for the lungs. And then there's the pelvic diaphragm. So the pelvic diaphragm spans across the pelvis itself. And that includes the 3 layers of pelvic floor muscles that we referred to earlier. This is where we are specialists in all of these tiny little muscles. But you can see how if we want that pelvic floor to work ideally, sometimes we have to look at the breath and vice versa. And there are actual pelvic therapists who specialize in the pelvic floor and the voice. So they're actually looking at the voice. So now we start to talk about speech therapy and respiratory therapy and trying to play on their techniques and what they're doing and just, and trying to come up with different ways of working with patients. Again, the law of minimal gains. We're trying to look for where we can make small gains to add up to a big result. Again, let's go back to this Coke can analogy in the middle of your body. So what can make the system crumble? Well, first, I just want you to give you a visual of what dysfunctional pelvic floor can look like. So remember I told you they're supposed to work together as a piston, and when they work against each other, then bad things can happen. So in this situation, I don't know if you can see well, first of all, these are roosters that are having eggs, which is totally dysfunctional. But if they were chickens, and that would be a little more appropriate, but you can see that the chicken sneezes and the eggs get splattered on the wall behind them. So that's a dysfunctional pelvic floor. She should be able to keep her eggs where they need to be and not lose them when she sneezes. So this is a lot of what we deal with pelvic floor dysfunction. So again, what can make the core crumple? So poor posture. This is a lot. You don't think about your posture when you're trying to take a deep breath, but if you are hunched forward, if you're kyphotic, if you're limited in your thoracic spine and your ribs, and you're trying to take a breath, not only are you limiting, the space that you're working with, but you're also putting a lot of undue pressure on the abdomen, everything below. And so that would lead to urinary urgency, and that would lead to incontinence, and that would lead to either like losing bowel function, and in some people chronic constipation, because you need proper pressure in order to be able to, for proper digestion to happen. Let's see. So decreased soft tissue or ligament integrity. This is what we see with pelvic organ prolapse, ulcers. So After years and years of coughing and weakness, some people develop ulcers. There's also separation of the abdomen. This is called diastasis recti. That's a couple of bullet points down. All of these things can lead to not being able to take, not having good pelvic floor function, as well as, respiratory function. And again, I know that it's more complex than that, but just imagine again how we can try to optimize what we're working with in order to have better, good results. Ulcers, abdominal weakness, lack of coordination of your breath, core and pelvic floor, the diastasis recti that I referred to as well, compromised lung function, chronic cough. We'll have people who come in after a bout of pneumonia, or they had COVID or whatever it was that they were coughing, or asthma exacerbations, and all of a sudden they have a prolapse that they didn't have before because of all the increased pressure and the stress on all of the pelvic organs. So again, making that connection between respiratory function and pelvic floor function. Pelvic organ prolapse, I already mentioned that. Low back injuries in that Coke canister, I know that you remember seeing the back muscles. Those can also tie into pelvic function. Spinal cord or nerve injuries, abdominal scars and surgeries. You have no idea how many patients I have come in with so many surgeries, and again, I'm working on their scars in order to improve their pelvic health or in order to improve their abdominal function. The scarring can have a big impact on how well your body can coordinate and move and function. And chronic constipation. So I'll be talking about this later. Usually this gets more attention than anything else because a lot of people are constipated. It's like the silent killer of the pelvic floor world. So we'll be talking about that a little bit later. Signs of pelvic floor dysfunction and COPD. Urinary urgency or incontinence. So like I said, in some situations, there's so much pressure buildup either from your posture, from the abdominal distension, that it's actually causing constant pressure on your bladder. So you feel like you're constantly going to empty your bladder. There are other conditions and other things that will lead to the urgency as well, but don't mistake that for, it's not always just about the bladder function. Sometimes it can be about pressure on the bladder. Or incontinence, like we already mentioned, that idea of the chicken with the eggs on the back wall. Chronic constipation or bowel incontinence, distended abdomen and bloating, gas, constipation, trapped air from the CPAP, and also dyssynergy of the breath and the pelvic floor. This was from a study that was done where they were trying to study urinary incontinence in women with with COPD. This study had its challenges, so I didn't want to focus so much on the results. The challenges were that the subjects had a lot of other comorbidities. I don't know where they were pulling their subjects from. But the point of this slide is to just to reiterate that the constant coughing and intra-abdominal pressure increases the stress on the bladder, increases the stress on all the structures in the abdomen and the pelvis, and therefore can cause the pelvic floor dysfunction. Other causes of bowel and bladder problems are side effects of medication, comorbidities such as diabetes, congestive heart failure, edema, blood pressure issues, prostatitis, vaginitis, age. So we have to take all of that into consideration when we're treating patients for pelvic floor dysfunction. And then also, there's a lot of work on the central nervous system now and the autonomic nervous system. I don't know if you want to Google or look up vagus nerve, but you're just going to enter a whole other mind-blowing world. Basically, the vagus nerve and your central nervous system are the accelerator and the brakes for all of your organs and all of your organ functions. If you have a condition that for some reason is affecting your breathing, the body doesn't always interpret that as, oh, they have COPD, and therefore they're breathing shallow. No, the body, back to our roots from cavemen and cavewomen times when we were being chased by tigers, the body will say, this person is panting, this person is breathing shallow, I think I'm going to be eaten by a tiger. So it starts to ramp up everything else. So now your sympathetic nervous system is ramped up, which then gives you the urgency, which then either gives you diarrhea or it stops your digestion. Your heart rate can accelerate. So these are things that we're working with in pelvic therapy as well, is teaching and educating people about how being able to take those breaths and slow down those breaths can actually talk to your central nervous system. So again, it's very extensive. The types of incontinence, I just want to be clear about the types of incontinence that we are talking about and can help with. One is stress incontinence. So stress incontinence means that there's not really anything wrong with the bladder. It's just all about the pressure on the bladder and or the muscles, there's weakness, or the structures around it. So that there's no medication to treat stress incontinence. That is something that you need to address the structures, you need to address the pressures, you need to address the muscle function. Urge incontinence, like I said earlier, this can come because of the pressures as well on the bladder or the urethra, where the urethra constantly feels stimulated, nerves, other things. There are medications for urge incontinence, but that it's not always the fix. Like I said, sometimes we're treating with the breath, and sometimes, to calm the central nervous system down. Overflow incontinence, also where we're trying to get people on a bladder schedule so they're not waiting too long, because the bladder gets so distended that it just can't hold back urine anymore. So that's where we put people in on a bladder schedule. That's not necessarily treated with medication either. And then there's the urogenic incontinence from like spinal cord injuries and nerve injuries, and that's a whole other way of treating, or a whole other line of treatment for the bladder. We cannot forget about nocturia, which is when you get up and to the bathroom, get up into the bathroom, get up into the bathroom all night long. The most fascinating thing about this is when people realize, again, I have patients come in and I say, is it your bladder that's waking you up, or is it something else? Is it hot in the room? Is your spouse moving around? Is somebody making a lot of noise? Is your baby waking up? Because we don't realize that good sleep hygiene, as important as we've seen mentioned with just the, the maintenance of COPD, what it does is when you're sleeping, your body actually puts your bladder to sleep. So it releases antidiuretic hormone during your REM sleep. If you never get into REM sleep, your bladder just continues to function like it's daytime. And then it also sometimes will play catch up, because we'll see with some people, like with Parkinson's patients, where they don't go often enough. Now they're lying on in supine. There's more filtration through the kidneys at that time. They're not sleeping. They're never getting into the REM sleep. And now their kidneys and bladder are in overdrive. So that's a big thing. Just look at what's waking you up at night. You may not be getting into a deep enough sleep state that you are actually releasing antidiuretic hormone. So also something else that we help treat. And then retention, which can happen for lots of different reasons. Okay, so let's find your pelvic floor and how you should use it. So if we think about the breath, remember I said when you take a breath in, if you want to put your hands on your low belly, I want you to feel your belly go in and out with your breath. What I'm looking for is more of a deep belly breath. So when you take a breath in, that belly should expand. And then on your exhale, I tell people, squeeze that pelvic floor, which is basically those muscles that you're sitting on. Squeeze them and raise them up toward your head, like the elevator's going up. And then exhale. And you should feel the abdomen coming inward. You shouldn't feel your abdomen pushing into your hands. That would be dysynergia. We're looking for the abdomen to pull in as that elevator is pulling up. So that's a good pelvic floor contraction.
It's not a good pelvic floor contraction if you feel your bottom squeezing, if you're rising up out of your chair, or you're pressing your legs into the floor, or you're feeling that your abdomen push out into your hands, or you're holding your breath. A lot of people breath hold, so that is where we start to get into trouble. That whole accordion action, now you're holding your breath and increasing the abdominal pressure as you're contracting that pelvic floor. You're just working against yourself. There are exercises that can kind of trick your pelvic floor into being more active. If the breathing is hard to do, for whatever reason, we will go to the hips and glutes. So we'll have people doing squeezes with a ball. This is called roll for control when you do this combination of exercises. So you're squeezing with the ball to activate the adductors or the inner thigh muscles. The adductors attach directly to the pubic symphysis, which then stimulates the pelvic floor. You can add a pelvic floor contraction with that, and then you do that in combination with pressing out, which will trigger or stimulate the rear triangle of the pelvic floor with your glutes. So for people who are really limited in their breath or have cognitively are not able to process the breathing because, like I said, it can be very complex, or are, limited for whatever reason. So I had a patient the other day saying that she was too tired and she couldn't think about the breath, so this is a good exercise for her. Suzanne Summer, she was onto something. So if you're squeezing those inner thigh muscles, you will stimulate the pelvic floor. Remember proning? This became very popular when we were dealing with COVID. When I was working at the hospital during the time of COVID, when we were in shutdown, we were suddenly getting lots of calls to go into patient rooms to help them with proning. So this is a position where the body just automatically goes into a more natural and functional way of breathing, where you can feel your belly expand and contract with your exhale. So this is often where I have my patients who have a lot of dysfunction. I have them lie on their bellies and we start to work on their breath. Trying to improve your thoracic, you get really stuck in your rib cage. So these are a couple examples where you're doing rotations, also working on that breath where you're expanding into your thighs if you're in a child's pose. We can show you, if you come up to our table, how to do rib expanding exercises where you're trying to improve the expansion in the rib cage, in the lower rib cage. When you have respiratory dysfunction, you get really stuck in the ribs. It can get really rigid, and it just doesn't expand for you anymore, because if the lungs aren't expanding, then the rib cage doesn't really do anything. It gets really stiff, kind of like a stiff spine. So this is another exercise that we're doing with our patients. I'm going to skip through because I'm almost at the end of my presentation here. But I just wanted to talk to you about one patient. We can talk more. You can come up to our table. We'll talk more about that. But I want to tell you about Janet. She was a patient who traveled to Pakistan, and she had developed pneumonia while she was there. And after that, it was a very severe case. And after that, she developed pulmonary fibrosis. So she came to my clinic because she was having pelvic floor dysfunction. She had bladder leakage. I got her on the table. I was trying to work with electromyography for her to get her to strengthen those pelvic floor muscles. Her breath was a mess. So I took everything away. I said, we're not working on anything but your breath. She was someone who had to use oxygen for air travel. And her goal was to not have to use oxygen for air travel. Again, that was something that she probably would have expected to be working with a respiratory therapist on or something. She did not expect to come to pelvic therapy to work on her incontinence and suddenly be treated for her breathing. But I took everything away. We started working in that prone position. We started working with that rib expansion. We started working on her abdominal strength. She was able to then go to Pilates, and because of those things, she was able to get off of the oxygen for air travel, because we put all those little bits together, and it kind of optimized her function, and it took her from something that she was dependent on for a few years now to a place where she could travel and not have to use the oxygen. So those are those mind-blowing cases where you're like, you know, we noticed there was dysfunction. I'm not going to only focus on this tiny little area. I'm going to broaden a little bit, think outside the box, and now we've helped her bladder function. We've also helped her respiratory function. We've helped her strength. She's more active. She was happier. She was able to walk up the stairs to Pilates. That was a big deal for her. Anyway, so that's the end of my presentation. I know I skipped over some slides because obviously I was ambitious and I didn't expect to be crying at the beginning. But anyway, thank you, John. That was a really powerful, especially for me as a provider, and thank you for allowing me to present.
Does anybody have any questions?
Yes. Oh, microphone. Sorry, I didn't know the drill.
Hi, have you heard of the Elitone machine? Is it like the EMG?
I have heard of the Elitone, and I have used it or trialed it. I am not a fan. I know that it works for some people, but Elitone does not target the right muscles. And when I worked, my feedback to the maker of Elitone was that that you're not targeting the right muscles. The muscles are a little bit deeper. Elitone is very much on the surface, and it all depends on how you place that. Yes, you're getting electrical stimulation to the general area, but it's not necessarily targeting the right muscles. In some people, it actually can cause more dysfunction. So I can reproduce the same thing and a lot more focused on the area that I needed to be on with just using a regular TENS machine. So again, it's a lot of money for something that's just kind of put this on there. You feel enough stimulation, so the consumer is, you know, feeling like something's happening, and it can work. It can work for some people, but I don't necessarily. I'm not a big fan of Elitone. There are other products out there that are better. EMG is different. So Elitone is using electrical stimulation to stimulate those muscles. EMG is reading what your muscles are doing and then training you to be better and more efficient at using those muscles. So if we have a very low level of electrical activity coming from those muscles, then we try to activate more muscle fibers and strengthen, and you should see that EMG reading rise better as you get stronger. And again, the TENS, we do use electrical stimulation. We're more focused with an internal sensor, so we're right on the muscles. And it's a passive way of us stimulating your muscles. Your muscles give off electrical impulses, and we can deliver electrical impulses to them to make them stronger, more efficient, more active, which again is what the Elitone attempts to do, but not in a very focused way. So again, I think it's a product that helps some people, but I feel that there are better ways of stimulating and strengthening the pelvic floor. Kind of the same as the chair that you sit on. I forget what it's called right now. But anyway, you're sitting on a chair, and again, are you targeting the right muscles? Is there a placebo effect, which the placebo effect is very powerful, but you know, when you're paying thousands of dollars for something that's just kind of making people feel some kind of stimulation, I don't think that's the most ethical practice. And so we actually get a lot of the flunkies from those programs, which they said, I've spent thousands of dollars on this, or I bought this product or that product, and then they come in to actually learn where the pelvic floor is, how to use it, how to strengthen it, and get some good results. And the first thing they say when they see our EMG is, wow, like I didn't realize that's the area that I should be working. I didn't realize it, you know, I can actually see that. That's really powerful for me to be able, it helps them gain control and actually learn rather than putting on a passive device. So like I said, the Elitone has value. I just don't think I think it could be a better product. Yeah.
Any other questions? Okay.
Yeah,
If you do,
there's if over, is there a way they can find more about your speech later?
can we share your slides?
Oh, yes. Yeah, I know that I glossed over and skipped the whole constipation part, which usually people are really interested in, like how can I go poop better? That might be a different, like a whole other presentation. I'd be happy to talk to you about it more. I'd be happy to share the slides as well. Yeah, of course.
Okay. Valerie just also nominated our speaker to do a support group. So if you want to hear more and get more of that presentation, you're just going to have to go to the support group. But thank you very much, Deborah Weber, for sharing with us. I could see everybody in the audience. Everyone was trying to breathe better and secretly squeezing Kegels. I know you were. And hopefully, everyone will get a stronger pelvic floor. Thank you. For our next discussion, we have a recorded presentation.
Hello, everybody, and welcome. I'm Dr. Valerie Kacho.
So she just introduced herself, and I will press play, and we will have an opportunity to watch this pre-recorded presentation. If you do have questions, feel free to put them in the chat or let us know, and we'll try and answer those either while we're here today or during one of the support groups. So here we go. Oh, nope. Let's try it again. So glad this is on YouTube, Val. Thanks.
Hello, everybody, and welcome. I'm Dr. Valerie Kacho. Today, I'll be discussing sleeping well with COPD. Let's get started. So a little bit about me. I'm a practicing clinical physician. I've been in practice for over 11 years now, and I specialize in integrative sleep medicine and also women's sleep. I'm double boarded in sleep medicine and integrative medicine as well, and I have my own private practice for folks who live in Hawaii and in California. And I'm really passionate about teaching my community about sleep health, all the different aspects, as well as whole living. And I also create videos specifically for women's sleep over on YouTube at Sleeporia. Thank you. A disclaimer before we begin, all the information provided here is just for educational purposes alone. Even though I am a medical doctor, in this setting I'm not your doctor, so if anything comes up for anything we discuss, please discuss it with a licensed medical professional. Alrighty, let's get started. So what is sleep? We all do it. It's just as important as drinking water, exercising our body, eating healthy nutrition, but what actually happens to our bodies and our brain when we do sleep? Well, simply put, our brainwaves slow down, our muscles then relax, and then we lose consciousness. So we're not exactly aware of all the things that are happening when we do sleep. Alrighty, audience participation question. How many hours of sleep do adults need? A, at least 6 hours, B, 7 to 8 hours, or C, as much as we can get, Doc? Well, adults need 7 to 8 hours. Some reports say up to 9. So there was a huge research study done in Canada of over 4.4 million people in over 30 countries. And they looked at 13 different health outcomes. And most of the health outcomes were quite better if you slept at least 7 hours of sleep. So shoot for 7 as much as possible. If you're getting less than 6, I wouldn't recommend that. Try to get at least 6, but 7 to 8 is the ideal number for most adults. Well, how important is sleep? What's going on in our brains and bodies when we do sleep? So number 1, right? It's really important for our heart health. Your heart is a pump, and if you're up for a long time, it really does have to work harder and harder, right? If you look at your computer, if you have a Windows device, it actually has a sleep mode. So, right, your computer can't be on 24/7, or it probably shouldn't be. Sleeping less than 6 hours has been associated with increased risk for high blood pressure. Also, what happens when we sleep, we have this trash collector that I like to call it, and it cleans up the waste or toxins throughout the day. And this happens in deep sleep or stage 3 sleep. So you want to make sure that you get enough sleep so all the toxins, all those excess proteins that we don't need anymore are cleaned out, flushed out of our brain, and then the next day we can start afresh. Yeah. So sleep is really important for our brain health. And also our metabolism. It's really hard to avoid those sugar cravings or maybe even lose weight or control weight if we're not getting adequate sleep. So there's hormones of our appetite. They're called ghrelin. Ghrelin makes you feel full. Leptin makes you want to eat more. And so when you're not getting an adequate amount of sleep, we tend to crave more junk food, and we don't process sugar as well. We can be what we call glucose intolerant. So not a good thing. Try to get as much sleep as you can, ideally at least 7 again. So let's really dive in to talk about obstructive sleep apnea. It's a really common condition and pretty much what I see in probably 80 to 90% of the patients in my clinic. So obstructive sleep apnea, as you can see in this picture, if I cut your body in half, we're taking a picture from the side, the normal breathing process happens when air goes in through the nose, through the back of the throat, down to the lungs off screen. But the part I'd like you to focus in on is right here. It's the back of the throat and the tongue. So snoring is partial obstruction of the airway, sort of like whistling, right? And if the airway is so collapsed, then that's when we see the obstruction part, right? Or the apnea. So when the tongue is falling back, air has a hard time going through. So if you're holding your breath for at least 10 seconds, 5 times an hour or greater, we call that obstructive sleep apnea. Certainly, if you have a crooked nose or a lot of allergies, that can impact how much air and oxygen come into your body, but oftentimes it's the tongue. So it's 3 things, right? Physical blockage of the airway. It only happens during sleep. So some of the people that I work with, they say, oh, I have difficulty breathing during the daytime. That isn't necessarily sleep apnea, right? Because sleep apnea happens when you're asleep. And then apnea, remember, no airflow or cessation of airflow. And what are the different signs and symptoms? So if you're not sure if you have it, right, it's best that you talk to a doctor about what you're going through. So observed apneas, right, if you see someone stopping breathing, typically you don't know that this happens. What you may know is that maybe you can hear yourself snoring and that wakes you up, or maybe you wake up gasping and choking. That's when your brain's like, hey, you gotta wake up and breathe. Sometimes some of the folks just report difficulty staying asleep, but they're not quite sure why this is happening. Sometimes people say they're just unrefreshed in the morning and they need, more than 8 hours of sleep just to feel good. Daytime sleepiness, falling asleep at the wheel, falling asleep in meetings. Headaches in the morning are also associated with sleep apnea. Memory impairment, remember we talked about that system that flushes out the toxins in your brain at night. That doesn't work as well when you have obstructive sleep apnea. Poor concentration as well. Urinating at night, I like to describe this one. It's called nocturia. If you wake up more than 2 times a night to urinate, what could be happening is that there's an increased pressure in your intrathoracic cavity, meaning right when your tongue is falling back, think of it like the plumbing in your system, there's a narrowing. Downstream, there's more pressure. So a narrowing here puts more pressure in your lungs. When there's more pressure in your lungs, there's more pressure on your heart. Your heart will stretch and signal down to tell your kidneys for you to wake up and urinate. If that happens 2 times or more or greater, we call that nocturia. Certainly drinking a lot of water at night, prostate issues, bladder issues can lead to this, but so can untreated sleep apnea. And then when you don't get good quality sleep, guess what? Mood is one of the first things to go. I can definitely attest to that. So let's talk about some obstructive sleep apnea or OSA myths, right? Let's separate things that are fact versus fiction or myths. So the number 1 is you have to snore to have sleep apnea. So a lot of people who do have sleep apnea snore, but if you don't snore, guess what? It doesn't mean that you don't have sleep apnea. And also, if you don't snore on a regular basis, it also doesn't mean that you don't necessarily have obstructive sleep apnea, right? Snoring is partial collapse of the airway, and sleep apnea is more complete closure. And then you may not even know that this happens, so something to keep in mind. Only those who are overweight or obese or have obesity have obstructive sleep apnea. So definitely not. We have people who have underweight or even normal BMI. We have babies who have obstructive sleep apnea, and it may be more related to their facial features, right? Large tongue, small chin, arched jaw. So if you're not overweight or obese, or I've had people tell me, my neck size is normal. So for women that's less than 16 inches, men less than 17, it does not mean that you are not eligible to get a test for sleep apnea, because you can have normal weight or be underweight and still have that diagnosis. This one, obstructive sleep apnea only happens in people over 50. Again, I mentioned, right, kids can have sleep apnea, babies. I would say that's typically more of tonsillar issues. Sometimes in the 20s and 30s, it could be more family history or weight related, but I do have a lot of folks in their 20s who are coming to see me for signs and symptoms of obstructive sleep apnea. Definitely your risk increases as you get older, and we do see higher rates above 50, and that's because as you get older, unfortunately, the muscle tone decreases. So you have more atrophy, and that can lead to more sleep apnea. Atrophy is decreased muscle tone, so there's more floppiness of your upper airway. Another myth is OSA is only diagnosed in the sleep lab. No, technology is pretty amazing. I'll show you a picture about what it looks like. You can do the test in the comfort of your own home, which I think for a lot of people is one of the biggest concerns about even getting tested and treated, because they didn't want to go to the lab with all the wires on or have somebody watch them when they're actually asleep. And then the last myth is CPAP is the only treatment option. Definitely not. It is the best treatment option. I'm going to say that out loud. A lot of people think like, you know, doctors are just pushing CPAP on patients, but it actually does work, and it's the gold standard. One thing that I do want to talk about is that there's a huge gender bias in sleep medicine, in medicine in general. But a woman will come and see their doctor, and if they say that they're tired, may not have all the classic symptoms. We know up to 40% of women don't necessarily snore, gasp, or choke, or stop breathing, and they're told that they have thyroid issues or depression, which you may have actually. Sometimes thyroid conditions, low thyroid can mimic symptoms of sleep apnea, but they aren't offered a sleep apnea test. And some of the studies do show up to 90% of women who potentially could have sleep apnea aren't even diagnosed. So definitely, if anything from this lecture today, this talk today is, if you're feeling tired, if you feel like your sleep is off, you know, just talk to your doctor if you'd be a good candidate to get a sleep study. Alrighty, so let's talk about making this diagnosis. Yes, we still do have in-lab sleep studies. There's a lot of sensors on your body, and there are certain people who do best in the lab, meaning, you know, if you do have COPD and you need to be on oxygen, you're better studied in the lab. If you have a history of arrhythmias or maybe congestive heart failure or seizures or act out your dreams, typically people who have more chronic or critical conditions are best studied in the lab. Home tests are for those folks who really, and this is actually something that's sort of depending on insurance. A lot of insurances say be studied at home because it's a lot cheaper, but it's pretty nice. Actually, it's more comfortable to sleep at home. I often recommend it to my patients as a first-line test because it represents really more of the real-world environment, so how you typically sleep. It's hard to see with this picture. There's a nasal cannula that you put in your nose that monitors the air moving in and out. There's a PagerTech device that clips to your shirt, monitors snoring and body position. The belts will monitor if your lungs are moving up and down. A wrist device that tells us if you're awake or asleep based upon motion, and then the finger probe for your oxygen and your heart rate. So that's one option. There are other options that are just like a ring on your finger, other options that are patches underneath your right rib cage over your belly button. There's another option that's just like a watch device that goes around your wrist and your finger probe. So a lot of variety of options where you can diagnose obstructive sleep apnea in the comfort of your own home. And then let's move on to treatment. So what does this waving arm balloon represent? Well, it stands for the continuous positive airway pressure. So if you imagine your throat collapsing at night, all we do is force air in to help you breathe. The way we do so is through a mask on your face. Sometimes the mask can just sit underneath your nose like this. Sometimes they cover your nose over your nose, or sometimes they cover your nose and your mouth. We call those full-face masks. So this is one example of a CPAP machine, continuous positive airway pressure. We also have automatic CPAPs where you put a range of pressure and we let the machine decide how much pressure you need. And then there's also bi-level or BiPAP, which is one pressure when you inhale and then another pressure when you exhale. And so non-CPAP treatments, right? You know, CPAP definitely does help, but certainly not for everybody. Some people can't tolerate anything on their face. There are mouth guards or mandibular advancement devices. What those do is they move the jaw forward, giving you more space in the back of your throat. It moves the tongue out of the way. If you have big tonsils, removing that can help. Think of your throat like a room, and the tonsils are like big furniture, so removing that, opening up the airway can help. We used to do this procedure a lot. It's called the U-triple-P, removing the uvula, but the tongue can still fall back, and so the results from this aren't as good as probably using the CPAP, and it can be a painful surgery. Also, straightening out the nose if you have a crooked nose. Again, doesn't necessarily treat sleep apnea. I would say it helps more with snoring, but it can also make the mask a lot more comfortable. If you have a hard time breathing through your nose, then you need a lot more air to push in. So having your nose open, right, by having that septoplasty can help. And then another option that I want to talk about is this. It's the hypoglossal nerve stimulator. It's pretty cool technology, and all you need is this. You just use this to turn the device on and off. And so it sort of works like a pacemaker. There's a device that's the battery here, and it coordinates the breathing simulation. So there's a wire that goes near your lungs, that's the breathing sensor, and when your lung starts to move, there's a wire that goes to the nerve to your tongue, and it makes your tongue go forward like this. So the goal is to move the tongue out of the way to open up your airway. It's only for folks who have moderate to severe sleep apnea, but it's actually been pretty cool. It's neat how there's just new treatment options. Other options include things like weight loss. There's some obesity medications that they're trying to get FDA approved. There's also other medications that are supposed to help open or help control the brain center to help you breathe. We're not quite there yet, but I do think within our lifetime we'll have a pill that opens up our airway. All right, let's jump into talking about obstructive sleep apnea and COPD, where we call this the overlap syndrome, or OS, overlap syndrome. Okay, audience participation question. What percentage of patients with COPD have been found to have OSA? What do you folks think? A, 12 to 25, B, 35 to 62, or C, 56 to 84? Alrighty, if you guess C, you are correct. Yeah, pretty high rates of folks with COPD have obstructive sleep apnea, so up to 84%. Why? Well, aging and male gender are associated with both. Remember, as we get older, right, we have more collapse of our upper airway, we have more muscle atrophy. And the data does show it starts with obstructive sleep apnea and then COPD develops a little bit later. What are the symptoms for overlap syndrome, right? Poor sleep quality. Folks with COPD do report poor sleep quality. Excessive daytime sleepiness. If you're not breathing well, it's hard to get rest and your brain's constantly waking up. Headaches in the morning. This may be due to issues with gas exchange, having lower levels of oxygen, higher levels of carbon dioxide, shortness of breath with exertion, fatigue, waking up to urinate 2 times or more, nocturia we talked about, and even erectile dysfunction has been seen in folks with COPD and obstructive sleep apnea. So also what's associated with this is higher risk for blood pressure, hypertension, increased risk for cardiac issues such as heart attacks and even heart failure, right? If your tongue is falling back, choking off your airway, and if your lung parenchyma, right, if your lungs aren't doing a good job to give you enough oxygen, right, that puts a lot of strain on your heart and also on your brain and can increase your risk for stroke. And we've also found that folks with overlap syndrome are at an increased risk for depression. Sometimes your mood is really, that's something that goes if you're not sleeping well, and if also you're dealing with some chronic conditions. Well, how do we treat it? With positive airway pressure and then oxygen if you need it. Not everyone needs oxygen, but for some folks it definitely may be helpful. And one of the best reasons to treat overlap syndrome is what? You have a lower mortality, decreased risk for dying. You have less ER visits, you have less hospitalizations from COPD exacerbations, and even lower healthcare costs. So a lot of good reasons to look into sleep apnea if you potentially have it, and if you already know you have it, right, if you're one of those 84%, make sure that you're talking to your doctor about what treatment option is best for you. Alrighty, folks, let's transition gears to talk about top sleep tips. So what are the top sleep tips that I have to encourage folks to get better sleep quality, get better sleep health? Well, the first of this is just make sleep a priority. I know that we're all really busy people and we have a lot of things to do throughout the day, but if you're shortchanging yourself on sleep, it's gonna be harder to take care of your loved ones. It's gonna be hard to take care of yourself and do a really good job at work, right? Your brain works better when you're getting an adequate amount of sleep. Number two is, give yourself at least 7 hours of sleep. But I always encourage folks is to find out how much sleep you need. You know, think of it like the fuel in your tank. If you're gonna drive from one side of the island to another, how much gas do you need to get there, right? Just like how many hours of sleep do you need to feel good so you're not feeling like you're dragging or needing a nap. Yeah, so give yourself the opportunity to sleep at least 7 hours. And then number three, right, since I am a sleep doctor, I really want to make sure that if you do have an underlying sleep condition like obstructive sleep apnea, that it's addressed, it's fully treated, your treatment is optimized. And also if you have insomnia, you know, we do know that COPD is associated with depression and anxiety, and sometimes those conditions can impact our ability to fall asleep or stay asleep. So if you're not sleeping well, please talk to your physician about it. There's a lot of good treatment options out there. And I just wish you sleep well as you, and I just really wish you sleep well as you are continuing to do the best for your own health and your journey. So if you'd like to contact me, there's my information, my office information, my website, and my email. And I just want to really thank you all for your time and attention. I know you have a lot of places to be, but I'm so glad you spent the last 20 minutes with me. And please, if you do have questions about anything that we went over, feel free to reach out to myself at hello@sleeplifenet.com, and I'll answer your email. Alrighty, sleep well, everyone. Thank you.
Okay, thank you to Dr. Valerie Cacho. She pre-recorded that. And if you do have any questions, we will ask that maybe you write them down, let us know, and submit those. And Dr. Cacho offered to answer those via email, or you can get the answer at one of our support groups. Now, for our last discussion today, we have another recorded conversation that's very important. It's about the different treatments from two pharmacists from Queens West. Annie Madar.
Hello, everyone. My name is Annie Madar.
And I'm Tyler Millar. We are pharmacists at Queens Medical Center. But today, we are here to talk to you about the medications used to treat COPD. We'll discuss how these medications work, what you should know about taking them, and some tips to help you manage your treatment effectively.
Let's start with a quick overview of COPD. COPD is a chronic lung disease that makes it hard to breathe. It's often caused by smoking, but other factors like long-term exposure to harmful substances can also contribute. COPD is a slow progressing inflammatory respiratory disorder characterized by airflow limitations caused by inflammation and alveolar abnormalities, the air sacs that make up your lungs. COPD includes chronic bronchitis, where the airways become thickened and inflamed, leading to excess mucus production. This mucus can clog the airways, making it harder to breathe. Emphysema is another component of COPD, resulting from the damage to the walls of the air sacs within the lungs that are vital for oxygen exchange. The air sacs lose their elasticity and become larger, trapping air inside. This trapped air, combined with the weakened state of the lungs, makes it increasingly difficult to breathe. One of the most challenging aspects of COPD is that it progressively worsens. While there is currently no cure, there is hope.
The goals of treatment are clear. We aim to relieve symptoms, slow disease progression, improve exercise tolerance, prevent and manage flare-ups, and ultimately improve overall health and quality of life. One of the most impactful steps is quitting smoking and avoiding that secondhand smoke as well. Reducing exposure to air pollution, dust, and chemical fumes is also crucial in managing COPD. Eating a healthy diet is also always recommended. Medications can help manage symptoms and prevent complications. These treatments are essential in controlling the disease and improving the ability to breathe more comfortably. Vaccinations are also preventative care that can help to prevent things like pneumonia. It's vital for people with COPD. Vaccines help protect against respiratory infections that could worsen COPD symptoms. Oxygen therapy is another one. For some patients, oxygen therapy can be necessary to maintain adequate oxygen levels in the blood, helping to reduce shortness of breath and improve quality of life. The comprehensive program of pulmonary rehabilitation includes exercise training, education, and support to help individuals with COPD improve their physical and emotional well-being.
There are various medications available for managing COPD. Pharmacologic therapy plays a crucial role in slowing down the progression of COPD, reducing symptoms, and minimizing the frequency and severity of exacerbations. It's important to note that therapy is tailored to each patient based on their response to treatment and the severity of their condition. First-line treatment typically involves inhaled medications. These are the cornerstone of COPD management as they deliver medication directly to the lungs, providing quick relief and reducing airway inflammation. We'll explore the different types of inhalers and their specific roles. In addition to inhaled medications, we also have oral medications as a second-line treatment option. These are used in conjunction with inhalers or when inhaled therapies alone are insufficient to control symptoms. Lastly, there's an emerging class of treatment known as the biologics. These are injectable medications designed to target specific pathways in the immune system that contribute to inflammation in COPD. Biologics represent a novel approach in the management of COPD, particularly for patients with severe forms of the disease who haven't responded well to other treatments.
Inhalers are the cornerstone of pulmonary treatment for COPD. They deliver medications directly to the lungs, helping to relieve symptoms and improve breathing. There are three main types of inhalers used in COPD management: bronchodilators, corticosteroids, and combination products. In the following slides, we'll go through each one in detail.
The first class of drugs used to treat COPD are called inhaled bronchodilators, which are a type of medication that help people with COPD breathe easier by relaxing the muscles in their lungs and widening their airways. When these muscles relax, your airway opens up wider, allowing more air to flow in and out of your lungs. This is especially important for those of you living with COPD, where the airways can become narrowed and obstructed due to ongoing inflammation and structural changes in the lungs.
By opening up your airways, bronchodilators help reduce common COPD symptoms like shortness of breath, wheezing, and chest tightness. This makes everyday activities like walking or climbing stairs easier and less tiring. Many patients find that they can do more and feel better overall when their breathing is improved. Regular use of bronchodilators can also help improve lung function over time. This improvement can often be measured through a test called spirometry, which measures how much air you can exhale in 1 second, known as FEV1, or forced expiratory volume in 1 second. Many patients see their lung function improve with consistent use of bronchodilators, which is a great sign that the treatment is working.
Bronchodilators play a crucial role by helping to relax the muscles around the airways, clear mucus, and prevent airway tightness. There are two main types of bronchodilators, both working differently on the smooth muscles, but ultimately leading to the same beneficial outcomes. The first class of bronchodilators are called beta-2 agonists, named for the receptors they stimulate in the lungs. These are further divided into two categories: short-acting and long-acting agents. The short-acting agents, such as albuterol, Xopenex, and Ventolin, are designed for quick relief. They come in forms such as inhalers and nebulizers and start working within minutes. However, their effects only last about 4 to 6 hours, making them ideal for emergency situations, but not for long-term management. As a pro tip, always carry your rescue inhaler with you. Long-acting agents, including Brovana, Performis, and Ceravent, are used to maintain open airways over a longer period, ranging from 12 to 24 hours. Unlike the short-acting agents, these are slow to start, but are vital in maintaining breathing comfort throughout the day and night. By providing all-day symptom relief, long-acting inhalers reduce the frequency of rescue inhaler use. It's important to note that long-acting agents need to be taken daily and should not be used as a rescue inhaler. As a tip, results will be seen with consistency.
When using beta-2 agonist inhalers, it's important to be aware of potential side effects. While these inhalers are highly effective in managing COPD symptoms, they can sometimes cause unwanted side effects. A common side effect, especially with short-acting inhalers like albuterol, that many patients notice are tremors or shakiness, particularly in their hands. This occurs because the medication stimulates your muscles as it opens the airways, which can lead to a temporary feeling of unsteadiness. Another side effect to be mindful of is an increased heart rate, known as tachycardia. These medications can stimulate the heart, causing it to beat faster than usual. This is usually temporary, but can be concerning, especially for patients with pre-existing heart conditions. If you feel your heart racing or skipping a beat, it's important to take note of it and discuss it with your healthcare provider. Some patients also report feeling nervous or anxious after using their inhaler. This jitteriness is related to the stimulant effect of the medication, which can make you feel on edge or uneasy. While this effect typically subsides, it's something to be aware of, particularly when you first start using the inhaler or if you increase your dose. Headaches are another possible side effect. These can range from mild to more bothersome depending on the individual. If you experience frequent headaches after using your inhaler, this is something you should discuss with your doctor as well. Muscle cramps can occur as well. Again, due to the effect on muscle tissue, while not everyone will experience this, it's a side effect to keep in mind in case you have any unusual cramping or muscle discomfort. Inhalers can also cause dryness of the mouth or throat, leading to a scratchy feeling or even hoarseness. To minimize this, it's a good idea to rinse your mouth with water after using the inhaler. This can help reduce irritation and prevent some of these symptoms. In rare cases, beta-2 agonists can lower potassium levels in your blood, a condition known as hypokalemia. This is more likely with frequent or really high doses, so it's important to follow your prescribed dosing schedule and let your doctor know if you experience symptoms like muscle weakening, cramping, or fatigue. Lastly, and very rarely, some patients might experience what's called a paradoxical bronchospasm. This is when your breathing actually worsens immediately after using the inhaler, which is the opposite of what we want. If this happens, it's critical to seek medical attention right away. Overall, while these side effects can be concerning, it's important to remember that the benefits of beta-2 agonists in managing COPD can often outweigh these risks. However, being aware of what to expect allows you to manage any side effects more effectively and seek help if necessary. Always communicate with your healthcare provider about any side effects you experience so they can help you adjust your treatment if needed.
Now let's move on to another important class of inhalers used in the treatment of COPD. Anticholinergics, also known as muscarinic antagonists. These medications work differently from beta-2 agonists. Instead of stimulating the airway muscles to relax, anticholinergics block the signals that cause those muscles to tighten. As a result, the airway remains open, allowing easier breathing. The anticholinergics are also broken down by duration of action into short-acting and long-acting agents. The short-acting agents, such as ipratropium, commonly known as Atrovent, are typically used for quick relief of symptoms. These are fast-acting, providing relief within minutes. And because of their shorter duration of action, their effects only last about 4 to 6 hours. They need to be taken multiple times a day. The short-acting agents are often used in combination with the short-acting beta-2 agonist during COPD exacerbations to provide rapid symptom relief. On the other hand, long-acting agents such as tiotropium or Spiriva, umeclidine, Incruz, or revefenacin, Uperi, are designed for maintenance therapy. These medications take longer to start working, but provide extended relief, often lasting up to 24 hours after just one dose. Long-acting agents are the key part of managing COPD on a daily basis, helping to keep the airways open throughout the day and night, reducing the need for rescue inhalers.
Just like with beta-2 agonists, there are some key side effects and tips for using anticholinergics that you should be aware of. One of the most common side effects of anticholinergic inhalers is dry mouth. This happens because the medication can reduce the amount of saliva your glands produce. To manage this, I recommend sipping water frequently, chewing sugar-free gum, or using a saliva substitute if needed. This can help keep your mouth moist and reduce discomfort. Another side effect that some patients experience is a bitter taste in their mouth after using the inhaler. This can be unpleasant as well, but it's usually temporary. To help minimize this, you can rinse your mouth with water after each use, and that will also help with the dry mouth. Some patients may also experience urinary retention, which means difficulty in fully emptying your bladder. This is more common in older men or those with an enlarged prostate. If you notice any difficulty urinating or a decrease in urine output, it's important to inform your healthcare provider as they may require further evaluation. Your anticholinergics can sometimes also cause constipation as well. To prevent or alleviate this, I suggest you increase your fiber from your diet, drinking plenty of fluids, and maintaining regular physical activity. If constipation becomes a significant issue, discussing it with your doctor is important, as they may recommend a stool softener or other remedy. Additionally, some patients might experience blurred vision. If the medication gets into your eyes, this is a higher risk of causing something with mists or powdered forms of the inhaler. To avoid this, make sure to use the inhaler correctly, directing the mist into your mouth and closing your eyes during administration. If you do get some in your eyes, rinse them immediately with water and contact your healthcare provider if you notice any persistent blurring or eye pain. It's also important to note that while these side effects can occur, many patients tolerate anticholinergics well and find them to be highly effective in managing their COPD symptoms. However, if you notice any side effects that are bothersome or persistent, don't hesitate to contact your provider. They may be able to adjust your dose or recommend strategies to minimize these effects. Lastly, consistency is key with anticholinergics. These medications are most effective when used regularly as prescribed, rather than on an on-needed basis. So it's important to take them every day, even if you're feeling okay. Keeping a daily routine and setting reminders can help ensure you don't miss a dose.
Now let's talk about inhaled corticosteroids such as beclomethasone, Qvar, mometasone, Asmanex, and budesonide, Pulmicort, or fluticasone, Flovent. These medications play a critical role in the management of COPD, particularly for patients with more advanced disease or those who experience frequent exacerbations, which are flare-ups or worsening of symptoms. Inhaled corticosteroids work by reducing inflammation in the airways, helping to decrease swelling and mucus production. This can make breathing easier and reduce the risk of exacerbations. The onset of action for corticosteroids is typically slow, often taking a few days to a couple of weeks to notice their full benefits. This is why they are used as a long-term therapy rather than for immediate relief. Most inhaled corticosteroids are taken once or twice a day, depending on the specific medications and the severity of your COPD. Corticosteroids are prescribed only in combination with long-acting bronchodilators, especially in patients who continue to experience symptoms despite using bronchodilators alone. The combination helps to maximize the benefits of both classes of medications, The bronchodilators keep the airways open, while the corticosteroid reduces inflammation. These combination inhalers are a key part of therapy for many people with moderate to severe COPD.
Inhaled corticosteroids are highly effective for many patients, but they do come with some potential side effects. The most common side effect of corticosteroids is a fungal infection in the mouth, known as oral thrush or candidiasis, which presents with white patches in your mouth, soreness, or difficulty swallowing. This occurs because the corticosteroid can suppress the immune response in the mouth, allowing yeast to grow. To minimize the risk of thrush, it's important to rinse your mouth with water and spit it out after using your inhaler. Some patients find it helpful to brush their teeth after using them. If you do develop symptoms of thrush, contact your healthcare provider. They can sometimes prescribe an antifungal medication to treat the infection.
Inhaled corticosteroids can also cause other potential side effects, such as hoarseness or a change in voice. It can also increase the risk of infection, such as pneumonia, and cause bruising or thinning of the skin.
To quickly recap, inhalers for COPD management usually consist of bronchodilators, such as beta-2 agonists and anticholinergic muscarinic antagonists, along with corticosteroids. Combining these medications into single inhalers simplifies the treatment for patients, making it easier to manage their condition effectively.
Combination inhalers are specially designed to offer the advantages of multiple medications into a single convenient device. These inhalers also fall into two main categories: the short-acting agents, known as rescue or reliever inhalers, and long-acting agents used for maintenance and prevention. Short-acting agents work quickly, providing relief within 5 to 15 minutes by relaxing the muscles around your airways. However, their effects are temporary. On the other hand, long-acting agents require consistent use over several weeks, typically 3 to 4 weeks, before their full benefits are realized. These agents not only help relax the airway muscles, but also reduce airway inflammation and mucus production over time. As you can see in this illustration, while short-acting agents offer immediate relief, long-acting agents play a crucial role in managing COPD by addressing the underlying causes of airway constriction.
Already be familiar with short-acting rescue or reliever inhalers like Combivent or Duoneb. These inhalers combine two short-acting bronchodilators like albuterol and ipratropium to quickly open the airways and provide rapid relief.
Combination long-acting beta agonists with a corticosteroid, such as Advair or Breo, are commonly used in COPD management. These inhalers combine a long-acting beta-2, such as salmeterol or vilanterol, with a corticosteroid like fluticasone. This combination not only helps to relax the muscles around the airways, but also reduces inflammation.
Medication important in the management of COPD is Anora ellipta. Unlike some of the more commonly prescribed inhalers, Anora ellipta is typically added by pulmonologists when additional bronchodilation is needed. This inhaler is unique because it combines a long-acting beta agonist, vilanterol, with a long-acting anticholinergic, imiclidium. This dual mechanism not only helps to relax the airway muscles, but also prevents them from tightening, providing more comprehensive control of COPD symptoms. In some cases, especially for patients with more severe COPD, pulmonologists may recommend a more advanced treatment approach known as triple therapy. This involves the use of inhalers like Trelegy or Breztri, which combine 3 different types of medications in a single device. Trelegy contains a long-acting beta agonist, vilanterol, and a long-acting anticholinergic, imiclidium, and a corticosteroid, fluticasone, making it the first once-daily triple therapy inhaler. Breztri, on the other hand, also includes similar combinations with a different corticosteroid, budesonide. Which makes these inhalers unique is their ability to address multiple aspects of COPD management by relaxing the airway muscles, reducing inflammation, and preventing airway tightening, all in one convenient inhaler. Triple therapy like this is especially beneficial for patients who need a more comprehensive approach to control their symptoms and prevent exacerbations.
Now let's move on to oral therapies that are sometimes used in the treatment of COPD. These medications are typically reserved for specific situations where inhaled therapy alone is not sufficient. The first one is called roflumilast, which is a phosphodiesterase inhibitor which decreases inflammation in the lungs. The most common side effects are diarrhea, weight loss, and nausea. Antibiotics such as azithromycin can also be used for patients that have frequent COPD exacerbations. Common side effects include gastrointestinal discomfort. Oral corticosteroids such as prednisone can also be prescribed for frequent exacerbations. The most common side effects include weight gain, increased blood sugar, mood changes, and osteoporosis. Make sure to taper your medication down as prescribed to prevent withdrawal symptoms. And lastly, we have theophylline, which is an older medication which is used to help relax the muscles around the airways. It's generally used as a last resort when other treatments aren't effective. Theophylline has a narrow therapeutic range. This means that the difference from a safe dose to a toxic dose is small, so regular blood tests are needed to monitor its concentration in the blood. Common side effects include nausea, headache, insomnia, and heart palpitations.
Precision medication has revolutionized how we treat diseases including COPD by tailoring treatments to each patient's unique characteristics. This personalized approach improves outcomes and reduces side effects. Biologics work by targeting specific inflammatory pathways to reduce the airway inflammation and improve breathing. While biologics have been successfully used in treating asthma and lung cancer, none are currently FDA approved specifically for COPD. However, they may still be prescribed if you also have asthma, as they can help manage both conditions. Because COPD is an inflammatory disease, targeting specific inflammatory pathways could offer more effective treatment. Common biologics include Fasenra, Dupixent, Nucala, and Xolair. Common side effects include injection site reactions, headaches, flu-like symptoms. These medications are either administered as a under-the-skin injection or intravenous through an infusion every 4 to 8 weeks, depending on the specific agent used.
Vaccinations play a crucial role in managing COPD by helping to prevent exacerbations. The following vaccines are particularly important for patients with COPD. The flu can be very dangerous for people with COPD, often leading to severe respiratory complications. Pneumonia is another serious risk for COPD patients, and the pneumococcal vaccine can help protect you against the most common bacteria that cause pneumonia. COVID-19 can have serious impacts on respiratory health, making vaccination crucial for COPD patients. Pertussis or whooping cough can cause severe coughing fits that are especially dangerous for someone with COPD. The Tdap vaccine, which also protects against tetanus and diphtheria, is commonly recommended for adults with COPD. The timing. Make sure to get your vaccines on schedule, especially before the flu and pneumonia season.
Managing COPD effectively is a journey that requires consistency and a proactive approach. By following your treatment plan, using inhalers and medications as prescribed, staying up to date with your vaccinations, and making healthy lifestyle choices can significantly reduce the risk of exacerbations and improve your quality of life. Remember, you're not alone in this journey. With the right support and tools, managing COPD within reach. Together we can make a difference in your respiratory health.
Thank you for your attention. If you have any questions, we'd be happy to answer them now.
Okay, and that was both pharmacists Anitan Madar and Tyler Miller, and I do believe we have them on the screen right now live. So if you have any questions, now is your chance. They are ready to answer those questions about any of the presentation that they gave on the different medications. Does anybody have any questions? If you think of one later, you can always ask those questions, put them write them down, put them on the feedback form. We can answer them during I see a question. They can also be answered during our support group meeting, but we need a microphone right here in the middle. It's coming to you.
I've been on many of the medications that were mentioned, but right now I'm taking Dulera. How efficacious is Dulera compared to maybe Zopanex and other ones?
Annie, did you hear that question?
I just wanted to clarify. The question is how effective Dulera is?
Mm-hmm.
Yes.
So I guess my first question to you is, are you taking it consistently?
Yeah, twice a day.
Twice a day, okay, awesome. So I believe in, for the rest of educational day, there's gonna be a section where the RTs will go over the techniques. So that's also another very important part to medications. Effectiveness is the way and how well you are actually absorbing the medication. But overall, Dulera actually has a very good, it's very efficacious as long as it's used properly, and has been shown to slow the progression of COPD. So does that answer your question?
Yes, it does. Thank you so much.
Awesome.
Any other questions from the audience? We have one in the back. Well, I think that was on the microphone, but it was a little hard to hear you. I don't know if it was turned on, but was your question about acid reflux and COPD?
Yes.
Now we can hear it. Okay. Well, Annie and Todd, I'm sure you're aware that there's a lot of medications we give for acid reflux, and any sort of acid exposure to the airways can cause a spasm or can exacerbate asthma and can also exacerbate breathing problems with COPD. So one of the things that's often recommended is to treat the acid reflux, whether it be with medications or whether it be with lifestyle changes or dietary changes, because if you do that, you can sometimes reduce the exacerbations that you might have from the asthma or COPD. Does that answer your question?
Yes.
All right. Thank you. And I think we have one in the chat. I think that was for incontinence. So I have a question for Annie and Todd. What's the best treatment for COPD? You kind of alluded to the fact that first you have to use it often enough as prescribed, and you have to use it the right way. Is there any one superior treatment to any other treatment for COPD?
That's a good question. You know, they have very strict guidelines on when each class of medications is prescribed based on your severity of symptoms. But honestly, they all work, the classes are all the same. So honestly, at the end of the day, it really kind of boils down to what your insurance will cover. And unfortunately, that's what I've seen happen a lot, is patients will kind of flip-flop between the different types of inhalers based on what the insurances will cover. But there isn't one that is better than another, as long as it is the right combination of drugs for your disease severity.
So basically, if you use it as prescribed, you use it regularly, and you make sure that you don't skip doses, what works well for your breathing is probably the best one for you.
Exactly.
Okay, and Val has a comment?
Actually, as a patient that has taken most of the medicines that are available for COPD over the 24 years I've had it, I would say sometimes you might have better control and fewer side effects using one combination or another. And if your insurance allows you or your pocketbook can afford it, and one is not working so well, you might ask your doctor, is there another medicine or combination I could try that perhaps might give me, you know, because I'm a little different from my friend or something else, could I try a different combination because I don't like the side effects and I don't feel I'm controlled as well as I'd like to be.
Agreed, completely, yes. Everybody's different and everybody will have different side effects and efficacy based on what medication, either dry powdered or HFA or nebulizer. So each one is different and you'll just have to find that combination that works best for you.
All right, thank you very much to our online Zoom edition after doing the presentation to join us live. We appreciate that. And really to all of our presenters today, both the ones that were here in person and also the ones that were online. Very nice to hear from Maya Nordstrom, or Maya Alba, and also from John Torrence with a very compelling story, from Deborah Weber telling us all about how to keep our pelvic health and keep it intact and make sure that we are preventing incontinence. We had Val Cacho with sleep and COPD, and we had our pharmacy team, Annie Todd Madar and Tyler Miller. So thank you to everybody who was able to participate today. If anybody has any additional questions, we can always answer them at a support group. And if you want to send those in later as well, you can do so online. The support groups, remember, are the third Wednesday of every October from 10 to noon Hawaii time. Every month? Yeah. Every month, Val said every month.